everybody. So now we've reached the time where it's time for your questions for our panel. And as I mentioned, Doris has a microphone. So if you put up your hand or stand up as the physical signal for Doris to come over and join you. And while you're warming up, let me ask, is there a hand?
Yes.
Oh, great. I didn't see that with the lights in my face. Thank you.
Hi, my name is Maria Levis, and I'm from San Juan, Puerto Rico. I was hearing you talk, and you were talking about the need to evaluate the changes, particularly with the Affordable Care Act and potential unintended consequences. The treatment of the Affordable Care Act in the territories is very different to the one in the United States. As far as all of the reports that we've seen, the changes that were made for the territories are technical, so they have more to do with territories' relationship to the federal government than to public health. Has anyone studied these unintended consequences? For example, the lack of an individual mandate in the territories, or other issues like, for example, when Dr. Jarris was mentioning the exchange for public health for access to health insurance cards. Puerto Rico actually went through that in 1993, and the results have been increases in maternal mortality and infant mortality as well. So just want some comment.
Great, thank
We
you.
are, we are state and territorial health officials, but frankly, it's been a challenge for us to understand the ACA in the territory. So I'd love to have your card and your name to talk to you about that. We'll be doing a lot more work in support of the territories over the next few years. So this is something we have to understand. It sounds like you know a lot more about it than at least I do. So
Great, and a reminder that the PHSSR portfolio needs to be looking not just at our states, but also the territories. While I'm waiting for some additional hands to come up, come on, I know it's the end of the day, but we've got to stay warm here. Oh, I see a hand over there. While you're walking over there, Doris, rapid fire, what's the best research example of impact that you use? What do you keep in your hip pocket? Do you have one? When you're trying to explain something? Come on, don't give me blank faces.
I mean, the return on investment from immunization, the return on investment from home visiting, nurse-family partnership is a good example.
Great.
Of examples
Or
used.
Glenn's work
Glenn's
about
work.
investment in local
Right.
health department resulting in healthcare cost savings. I mean, that in terms of the most direct public health
And the best,
ROI type.
And the best
argument.
example I'd give of why relationships are important and how this system actually works is what I watched happen during the stimulus, when the stimulus work was being funded. And votes were needed in the Senate to get the Stimulus Act passed. And a particular vote was needed, and the leadership in the Senate went to this particular senator and said, I want your vote. And that senator said, I'll give you my vote if you give me $11 billion for this particular initiative. The deal was struck, the vote was given, the appropriation was made, and the basic nature of politics, I think, is also important to understand, along with the best examples of research that have that we use.
Great, thank you. Question? Please introduce yourself.
I'm Joe Gibson. I'm an epidemiologist at Marion County Health Department in Indianapolis. And we've been having a lot of discussion within the health department about ACOs and how we're going to partner with them, what their role is going to be, what our role is going to be. How do you see ACOs, what kind of public health role do you expect for ACOs that's different than we now expect from the healthcare community? And where do you see the biggest opportunities for health departments to be partnering with them or to be subcontracting with them to accomplish some work?
Well, the model is meant to be that healthcare is now a cost center rather than a revenue center, and that there is profit in health, and that by organizing large enterprises and paying them what in essence is a bundled rate for a population served, that money can be made by keeping people healthy. The risks are obviously the money can be made, as we discovered about 20 years ago, in making care more difficult to be received as well, and then having people moved from place to place and plan to plan because there's no incentive to keep them in one place. But I think that part of the message from the local health department, or a collection of local health departments that are seeking to work with accountable care organizations, is to help them understand how it is possible to keep people healthy, keep a population of people healthy, whether they're thinking about that population in terms of the panel or the community they serve, whatever that happens to be, or a jurisdiction. Share the information that one has available. Have a clear idea if you want to contract with that accountable care organization about what the costs, what your own costs of providing those services are, and be able to talk about the detail behind those costs. Get familiar with the language of risk and reimbursement that those accountable care organizations are familiar with and will require from their partners. And if none of those is possible, simply see what can be done to help that accountable care organization connect with other organizations with whom you're familiar with, either by creating a place around a table in the community for them, or once again, simply getting them familiar with what you know and the work that you're doing.
So I guess I would suggest a couple of things. One is to look at some other models in some other states where I think people, in some communities and states where people are doing interesting things in creating this partnership, and going back to what Paul said this morning about being the chief health strategist for a community. Don't underestimate your convening authority. There are going to be several ACOs probably being created in your community, and so you can capture people outside that competitive space. Summit County, Ohio, they created what they call an accountable care community. Are using CTG money in part to support that, and it's functioning a little bit like an accountable care organization, but it's also thinking much more comprehensively and bringing multiple systems together to work together. In Maryland, local health departments are being given resources by the state to be that convening authority to bring the different systems together to make sure as they are adapting to the new delivery system that they are thinking about the broader population health. And one other thing that is sort of a sidebar, but not unimportant at all, sidebar to your question, but important to put out there, is that there are also all these state innovation model grants that CMS has put out, where states are being, and at least half the states, I think, so probably half of you are going to have this opportunity, where states are beginning to look at global budgeting of some kind. And we have to make sure public health is part of that conversation. Public health can be built into that global budget, as they're doing in Vermont. It can be to the side of the global budget, as they're doing in Massachusetts, where the global budget is just around the care delivery system, but they're making a separate investment through a wellness trust in public health. Or if it's completely outside that discussion, we're done for. Because legislatures will say, we took care of health, including public health, by doing this global budget. And if we're not inside, and if we don't have the data and the evidence to show what it looks like, and these are innovation grants, so there's an opportunity to do research and evaluation, the public health perspective has to be part of that research and evaluation.
So thanks, Jeff. These concepts, it is still a concept, the ACO. And frankly, it's not a new concept. 15, 20 years ago, there were these physician hospital organizations that received global capitations with a trend over the years, and they had risk corridors for money they could earn if healthcare cost less, and risk corridors if they overspent. And they didn't save a lot of money, and they didn't improve quality. And part of that was the break in incentive. The organization, the physician hospital organization, or the accountable care, or whatever they used to be called, would get that lump sum. But then once the money hit that institution, it was divided among the clinical departments based on fee-for-service billings. So it was still the incentive chain broke, and it was still a system based on generation of revenue. So somehow we need to change that dynamic. Now, the hope with the ACO is this talk about the triple aim, and part of that is population health. where they will be at risk for cost, for quality and patient experience, and for the health of the population. Great concept, except it's only that right now. There is not agreement upon what population health means. So if you happen to be I was at a CME for primary care docs, and population health was presented as the size of the patient panel they're going to make me take care of. For an insurance company, it's the enrolled. For the hospital, it's the customers who walk through the door. For public health, it's a geopolitical jurisdiction. So somehow we have to agree upon what a population health is and what population that ACO would be responsible for. The other issue we face is that we have no measures for population health. So the National Quality Forum, which is our congressionally sanctioned organization to develop quality standards, to adopt quality measures in this country. We had about a year-long process where there was a call for measures around population health. Kurt Stange from Case Western, who's a primary care, and I co-chaired that. Bobby was on it, and some other public health leaders. After all the work we did, I think we got 4 submissions. There is no group of measure developers for population health right now, where there's a ton of them NCQA. If you're looking at hospital health or health care, people that develop these measures validate them in a way that NCQA could adopt them. But until until National Quality Forum adopts population health measures, NCQA and Joint Commission will not adopt them, and then ACOs cannot be held accountable for population health outcomes. So I don't know if that's within your world of research,
Yeah.
but this is a burning need we have. Otherwise, these ACOs are going to be just like the old physician hospital organizations, and there'll be absolutely no improvement in population health. So we need the measures, we need the measure developers, however you folks can make them.
And
I'd also say that many
ahead, Bobby.
decisions are being made now in state capitals about how this new system will work. And so being brave, and if you're not at those tables where those policy decisions are being made, be brave and put yourself at those tables and be willing to make mistakes and to see one, do one, teach one, if you will, because the only way to get familiar with what's going on is to be in the middle of what's going on.
And I just want to underscore Paul's point about measurement. This is a huge issue in terms of especially in population health, because again, it's a concept that's being bandied about from so many different sectors. There's complete lack of clarity. And this is an area where I don't know who's working in measurement in the PHSSR community, but it's going to be essential going forward. And certainly it's an area Academy Health is also looking at, coming out of a workshop we did on population health. And so I hope that you all will, those of you who are interested in this issue of measure development, there's a deep field and expertise and methods in health services research on how to develop robust, good measures. And we need to adapt those methods and use them in PHSSR as well.
Part of the issue we faced was that the National Quality Forum's measures are really meant for clinical medicine, and a lot of the work we did was try to figure out how to morph them into something that was meaningful for population health and public health. But I would request that of you. If take a look at the NQF website, National Quality Forum website, and look at their standards for adopting a measure.
Right.
And then go see Scotch and have a lot of bourbon to drink.
Right,
Because they're
exactly.
really complicated, it's really difficult.
Great.
Ultimately, the databases that you're creating through your research could serve as the basis for the metrics that NQF is looking for. So you could begin to think long-term about the work you're doing and ask whether the data you're collecting could be used to produce the metrics.
Because we often think of the sort of the uptake of research into policy as, oh, something will get funded or some law or regulation will be made. But another policy lever is a measure will be adopted and then publicly reported and linked to payment or non-payment. And that is a very powerful policy lever as well. So it's a whole other way of thinking about how your research gets implemented nationally. So with that, we're out of time, Michael, sorry. But I want to thank our panelists. I know Glenn has some housekeeping that he wasn't able to do at the beginning of this session that I will call him up to do. But let's give a round of applause to our audience, to our panel.